Welcome to CDOC's quarterly Cancer Centers collaborative meeting. My name is Sheila Senyo Gerhardt, her Strategic Alignment Specialist in the Comp Cancer Program and California Cancer Registry. So while we are giving others time to settle in, please feel free to share your name, pronouns, organization, and favorite fall activity. Again, let's just introduce ourselves in the chat. Okay, so I'll go over some housekeeping while everyone is typing in their introductions. All participants have been muted, but we encourage engagement and participation throughout this session. While the chat is being monitored for questions, we'll also have an open discussion allotted after a presentation. So we hope you can assist us with also a short webinar evaluation post this webinar. The slide deck, recording, and any follow-up will be sent via email to all participants. Thank you all so much today for taking the time out of your very busy schedules to be here. Joining us are our Cancer Center Community Outreach and Engagement Leads and Program Representatives, CDOC Leadership and Partners, American Cancer Society Partners, and CDOC Work Group Chairs. Before we start with the agenda and presentations, next slide, I'd like to acknowledge our CDOC Chair, Dr. Sora Tenjusiri from the University of California, Irvine, and co-chair Dr. Allison Herman from UCLA Johnson Comprehensive Cancer Center. Sora and Allison, would you like to share a few words?
Yeah, just really briefly, welcome everyone. It's a pleasure seeing all of you, and I really look forward to our speaker for today. I think we can all share the painful, maybe common observations about restrictions in access to cancer screening, diagnosis and treatment, either through changes in reimbursement, policies regarding Medicaid funding, and certainly the things that are going on in our communities, particularly our rural, which were already underserved. And so I really look forward to dialoguing today about how we may be able to continue to support each other. If there's any forecasting about things that we think are coming down the pike that we might be able to band together around, I just really want to invite all those kind of ideas. And I thank CDOC and their staff for allowing this time for us to get together during this critical, with all our critical needs. Thank you. And Allison.
Yeah, I mean, you just said it all, Sora. So thanks everyone for being here. I think it's perhaps more important than ever that we get together and think creatively and strategically and think about how we can all support one another and keep our work moving forward. So thanks again. We'll look forward to the conversation.
Thank you, Sora and Allison. I'll go over the agenda briefly. So we'll hear some updates from American Cancer Society, Comprehensive Cancer Control Program updates, including cancer plan revision items, followed by a presentation from the Providence St. Joseph Hospital in Eureka. We'll also provide opportunities for discussion and collaboration, and we'll also have a chance to share and learn about other cancer center events, research, and other updates, followed with a quick wrap-up. To provide American Cancer Society updates, let me introduce our ACS partner, Bridget Freely, CDOC Vice Chair and ACS Associate Director, leading state partnerships in California.
Thank you so much, Sheila, and thank you so much, everybody, for the opportunity to present some updates. I know we have a full agenda, so I'll try to run through this quickly. We can go to the next slide. So as Lung Cancer Awareness Month, it's fast approaching in November. It'll be here before we know it. I just wanted to share some resources that hopefully can be helpful for your lung cancer and lung cancer screening related work. The American Cancer Society National Lung Cancer Roundtable has two new great resources I wanted to highlight. The first is the Steps for Increasing Lung Cancer Screening Guide for Primary Care Practices. This is a comprehensive guide that really offers evidence-based and expert-endorsed recommendations that help improve lung cancer screening rates, specifically in the primary care setting. We also have a new series of videos about lung cancer staging that are really designed for patients and families, just really to help to educate them about lung cancer staging, and those are available at the link there. I also wanted to highlight an upcoming webinar that's hosted by our state lung cancer screening work group, the CDOC ACS lung cancer screening work group, that's taking place on November 18th. It's around lung cancer and lung cancer screening. I know there will be more information and registration to come. And we can go to the next slide. The National Lung Cancer Roundtable I just mentioned, GO2 for Lung Cancer, the Radiology Health Equity Coalition, and the American College of Radiology are partnering for the 4th Annual National Lung Cancer Screening Day. This year it takes place on Saturday, November 8th. And the goal of this campaign, for those who aren't aware, is asks facilities to open their doors on the second Saturday in November to offer low-dose CT lung cancer screening. And I linked the website here if you're interested in learning more. There's promotional materials for the day and registration information if your facility is interested in participating. We can go to the next slide. One last lung cancer screening resource I wanted to highlight is from our state work group I mentioned before, the ACS CDOC Lung Cancer Screening Work Group. We created this California lung cancer story map, and essentially what it is, it's a website. It was also created in partnership with our American Cancer Society Geospatial Solutions team, and it includes interactive maps and a cohesive narrative about the lung cancer burden in California, and really the critical need to raise lung cancer screening rates in California, as ours are quite low. It has great county level data and educational resources, so we really encourage you to explore the site, share with your networks. We have a QR code, and the URL is getscreenedca.org. We ask that you share this far and wide. We are trying to get more visitors to the site. But just a quick note, this is really a resource that's designed for public health professionals, medical providers, key lung cancer stakeholders. It's not necessarily a public or community education tool at this time. We can go to the next slide. Some other upcoming webinars I wanted to highlight. The American Cancer Society's National Roundtable on Cervical Cancer is hosting a series of webinars focused on HPV self-collection for cervical cancer screening. And the first one is coming up on October 30th. This audience is geared towards FQHCs and safety net health systems, but we really do encourage anyone who's interested in this topic to attend. Registration is completely free, and I've linked the link and the QR code will take you to the registration. So please share this with anyone who might be interested in this topic. We can go to the next slide. Just a couple of upcoming learning opportunities. Some are ongoing, some are upcoming, about an ECHO webinar series for health professionals. And while some have already started, you should be able to register and access past recordings based on what I've heard from our team. So we have an ECHO webinar series for prostate cancer screening and primary care. We also have an additional one on cancer or building for pathways to fertility preservation and cancer treatment, as we know that's an important topic. And we can go to the next slide. And two other offerings, the one is on breast density risk in primary care. Breast density information will now be included in mammogram reports, so we really want to make sure that primary care clinicians are armed with this information and understand how to talk about this with their patients. And then finally, we have an ECHO on multi-cancer detection testing to really help clinicians understand the foundational aspects of these tests. The links to register, it's completely free to register. The links are on the slides as well as QR codes, and I know these will be shared out after the meeting, so please register if you're interested or share to anyone who might be interested in registering. And I have one more slide today. I just wanted to wrap up with an opportunity that's unique to cancer centers. This is a newer offering from American Cancer Society's QI Resource Consulting, or the QIRC. They're offering free quality improvement consultation to cancer centers that are serving disproportionately affected populations. And it really aims to help them with access to care and patient care for their patients. And the next cycle will run for about 6 weeks. It starts in January. There is an application, which I've linked here, also available at the QR code. If you're interested in applying, there is an application process, and that application is due on Monday, November 17th. Please click on that link. It will have more information about the program with the application, and then also a contact email if you have any specific questions. And I think that is it. So thank you all so much. I'm happy to answer any questions if there's time. But thank you so much for your time, and Sheila, I'll pass it back to you.
Thank you, Bridget. Do we have any questions for Bridget? Reviewing the chat. I don't see anything on the chat.
I don't see anything. Happy to answer any questions as they come up, or I can put my email in the chat too if anyone wants to reach out separately.
Thank you, Bridget. So in the next few slides, we're sharing Comp Cancer and CDOC updates that were covered in yesterday's CDOC All Members meeting. But since not all Cancer Center representatives are members, we want to make sure everyone has access to this information as well. I'd like to call on our program director, Shantae, to provide some state cancer plan updates.
Thank you so much, Sheila. Can you hear me okay? Okay, great. So just a brief recap, we know that California has had 4 state cancer plans since 2004. And so you see here all of the state cancer plans listed. We just completed the last one, which I'll talk about in these next slides. Also available is our cancer plan dashboard. So even though we just completed the new iteration, which goes from 2026 through 2035, we're still in 2025. So we're still working on those objectives through the end of the year, and we're still tracking progress on our dashboard. So this is just a reminder that this is still available. And while we won't have data for 2025 probably until 2027 or around then, we won't have that complete evaluation for our current plan until then. But just a reminder that we are still working on those objectives through our CDC action plan, the activities in our coalition with our current state cancer plan through 2025. So for our new plan, the 26-2035 plan, it is California's first 10-year state cancer plan. It focuses on health equity and prevention to eliminate disparities and improve outcomes for all California communities. We developed this plan, we started back in 2023, so late 2023, and then all of our subcommittees completed content by May 2025. We submitted to the California Department of Public Health for approval in July of this year. So right now that's going through the process. It is moving because I have heard some updates. So we do expect for it to be released in early 2026. This time around, the plan will be exclusively online. So it will be linked on our, it will live on the Comp Cancer CDPH website and link to our coalition website. And right now we are currently working on some implementation guides for the plan, which I'll show in the next slide here. Here is a draft that was drafted by our intern, which is one of the drafts for the implementation guides. We actually have an entire committee now that's set up called the State Cancer Plan Implementation Committee. So thank you to those who are serving on that committee. And they are creating these guides. We have prioritized groups that have been identified through a survey, and the committee is also working on solidifying those priority groups for which these implementation guides will be available for. So there's more to come on that, but know that we're working on just an outreach and dissemination plan for the state cancer plan.
Shantae, can I ask a question if you're taking questions about that?
Yes, please do. Please do.
I see in the example, it calls out what community-based organizations can do. Will there be any other recommendations, like, call outs, particularly cancer centers? Or is it primarily focused to CBOs?
No, so we have identified 5 to 6 priority groups, and it's all based off of what our members told us in that survey. But again, our committee is also providing recommendations for what those priority groups are. From my recollection, I think what was selected were policymakers, CBOs, local health departments, health insurers, and there were a couple of more. So we can make sure if you think cancer centers should be one of those, and I think they are. they are. So, but I'll definitely keep that in mind next time the committee meets.
Thank you, Shante. Thank you, Sarah.
You're
All right,
welcome.
for CDOC updates, next slide, a quick reminder about the CDOC orientation webinar. So we consistently post and remind workgroup members about the orientation webinar to keep it visible for both new and existing coalition members. It's a foundational resource that helps people understand CDOC's structure, mission, and how you can get involved. So we've included the orientation webinar again in all workgroup meetings, newsletters, and also on the CDOC website. And this approach really directly responds to feedback from previous evaluation finding reports at Comp Cancer, which highlighted a lack of clarity around how to get involved more with CDOC or limited understanding of coalition rules, work groups, and ways to contribute. So by embedding the orientation access into multiple touch points, we're working to bridge those knowledge gaps and support more meaningful participation. So we hope this helps you reacquaint yourself with CDOC and feel more confident about how to engage. I'll pass it over to Joyce.
Thanks, Sheila. We just want to remind everyone that CDOC welcomes all members to spotlight their work or recognize a colleague or individual who's done work in cancer control. So we encourage you all to share information about your project or someone that is doing work in cancer control by completing a form, which I'll be dropping in the chat. Your submission will be featured on the CDOC website, listserv, and other forms of communication. And you can learn more on our stakeholder on our member spotlight on our website. Next, I want to highlight that CDOC has launched a new initiative called Partner in Focus to spotlight a dedicated coalition member each quarter. The goal of this Partner in Focus is to foster collaboration, connection, and inspiration throughout the CDOC community. These quarterly highlights will be shared throughout the CDOC listserv and just showcase the unique roles and voices that strengthen our coalition. Lastly, I just want to share a CDOC partner event. So earlier this year, CDOC and UCSF collaborated to host a webinar featuring Find Help, which is an innovative platform that allows community organizations, governments, healthcare organizations, and businesses across different industries to easily manage and coordinate care. The webinar equipped participants with the knowledge and tools to access quality services throughout utilizing the Find Help platform. And what you see here on the slide is that Find Help is now hosting an in-person summit in San Francisco tomorrow, and I'll be dropping the link in the chat for more information. I'll pass it back to Sheila.
Next slide, Joyce. All right, Shante, HPV.
All right, so for the California HPV Vaccination Roundtable, and just a reminder that the Roundtable is a collaborative effort between CDOC and the American Cancer Society. It is our sister coalition. We are still hosting the California HPV Vaccination Learning Collaborative, where folks can come and learn about different best practices to increase HPV vaccination. We're bringing it back in 2026. It's a quarterly lunch series, the third Wednesday of each quarterly month at 12 p.m. It's 45 minutes long, and we have our dates listed there. I know Joyce will drop that link in the chat. So once you register on that link, you'll be registered for all of our subsequent learning collaboratives. If you would like to share any best practices and present at one of our collaboratives, please let us know. You can just contact us at info@californiahpvroundtable.org. And then there's also past recordings that you can find on our website that's listed here as well. Next slide, please. And also I wanted to just promote the announcement approach training that's also offered by the Engaging Health Systems and Provider Work Group for the California HPV Vaccination Roundtable. The announcement approach training, or AAT as we call it, is an evidence-based approach to increasing HPV vaccination endorsed by the National Cancer Institute. You can learn strategies for recommending HPV vaccination to promote vaccine acceptance and save clinical time. You can stay up to date on all of the latest HPV research. It's approved for 1 unit of AAFP elective credit. So we do have those CME for the CME for folks who are interested. And it's free. So it's free and it's only 1 hour and it's virtual. So if you and your health system partners are interested, or cancer center partners are interested, please let us know and we could coordinate that training for you.
Shante, this is also yours.
Okay, all right. For another update we have is with our colorectal cancer work group. We have been working with the American Cancer Society, California Colorectal Cancer Coalition, and the Department of Healthcare Services to coordinate a cancer screening webinar. So we're going to be focusing on, oh, I'm sorry, this is for BSIP. It's still a collaboration with the California Colorectal Cancer Coalition and the Department of Healthcare Services, excuse me. And the Department of Healthcare Services Every Woman Counts program specifically. So this program merges breast and colorectal cancer screening efforts together. We've been implementing this particular program for a couple of years now, and we're on cycle 3. The cycle 3 projects are actually wrapping up by the end of the year, and you'll see the clinics listed here. This project here work with FQHCs in California that are also EWC providers. It's important that they're EWC providers because we are trying to reach that target population. And they have submitted or they have went through a merit review process and have been selected to implement evidence-based interventions to increase breast and colorectal cancer screening. So this project specifically focuses on increasing breast and colorectal cancer screening in FQHCs in California. So you will see those projects there. And right now, we anticipate our cycle 4 projects to start in January 1st. The RFA was released in September. It's still out. So we'll include that link there for anyone who's interested or who knows partners who may want to apply. And the application due date is November 5th. All right, so now I can talk about the colorectal cancer or for the about the screening cancer screening webinar. Again, we are working with Department of Healthcare Services in their Medi-Cal quality division. We're working with the California Colorectal Cancer Coalition and the American Cancer Society to bring a webinar that's targeted towards health plans and specifically Medi-Cal managed care plans. There will be data presentations on cancer incidence, mortality, and screening trends. We're going to have updates on colorectal cancer, breast, cervical, lung, and prostate cancer screenings, covering any new guidelines, emerging tests, outreach strategies for underserved populations, policy shifts, and real-world success stories from we're actually going to be having these from health plans here. So there will be a couple of health plans presenting, as well as all of the other aforementioned topics. But again, the title of our webinar is Advancing Cancer Screening in California, Data, Guidelines, and Health Plan Innovations. It's on December 4th at noon. Registration is coming soon. So we'll have more information that we'll send out, and we can send that out on this listserv as well when we have that registration available.
Thank you, Shante. So for the Health Equity Work Group, they continued progress on its multi-year project focusing on underrepresented data in cancer research and care. So this is a continued collaboration with the Health Equity Work Group and CI designated cancer centers, CCR and other partners aimed at ensuring data health equity. So just a note that the project is no longer under the CDOC facilitated umbrella due to federal policy alignment issues, but the project's aim is to understand what types of demographic and identify data example, race, ethnicity, sexual orientation, gender identity, age, or income are being collected by cancer centers and to identify gaps. The proposed initiative of the CDOC Survivorship Work Group focuses on improving cancer survivorship outcomes by integrating a cancer care specialty into the certificate program for community health workers. So the project aims to establish standardized training and certification for CHWs in the oncology space, ensuring they're equipped to provide cancer care, including prevention, screening, and survivorship support. So the initiative involves initial outreach with various partners, including the Healthcare Access and Information or HCI agency, the ACS, City of Hope to develop and implement these standards. So emphasis is placed on aligning with existing programs and leveraging resources to create a comprehensive and effective training framework for CHWs. During our Cancer Center's open discussion later, you'll learn more about a new opportunity to collaborate on this project. And now moving on to our Cancer Center host presentation. In today's presentation, we have the pleasure of hearing from Providence St. Joseph Hospital in Eureka. Dr. Mary Ellen Mahoney is a trailblazing surgical oncologist and a native Californian born in La Jolla and raised in Monterey. She completed her undergraduate, graduate, and medical education at Stanford University, where she also became the first woman matched to train as a general surgeon. Her career has been marked by resilience through personal health challenges, advocacy, and leadership. At Stanford, she helped establish the trauma service and led a high-volume surgical practice. She also played a key role in designing Stanford's first comprehensive cancer center and co-founded Bay Area Cancer Connection, a peer support organization now in its 30th year. In the second half of her career, Dr. Mahoney and her husband, also a surgeon, relocated to Humboldt County to bring high-quality cancer care to a medically underserved region. There, she helped build a nationally recognized rural cancer program from the ground up and continues to serve as its medical director. Her work is a testament to the power of perseverance, community commitment, and academic rigor in transforming rural healthcare. Please welcome Dr. Mahoney.
Thank you very much. Here's the first slide. Yes.
Priscilla, we don't see your slide.
Here we go.
Thank you.
Okay. Next slide, please. Nice picture, and it's what it looks like here sometimes. Okay, so I, as a native Californian, knew nothing about this area of California at all. And part of the reason is the distance, and part of it is the terrain and the idea that if you like to drive along the coast, you get to Fort Bragg, and then to get to Humboldt, you have to go inland for an hour and a half. So most people interested in tourism, especially in the past, haven't done that. But I'm hoping to inspire a few of you to at least become tourists. I came up here kind of by accident. I called myself a human pinball, and I'm willing to say now that I was a prepared and educated pinball. But when the flipper strikes, get ideas based on your own experience, and this is what happened. It's important to recognize that our area is larger than the combined states of Connecticut and Rhode Island, and we are the only cancer care provider in the area. It makes statistical stuff to analysis much easier. But in good weather, the nearest cancer center is 4 hours away from any other cancer program. And although Oregon is closer, many of our patients are on Medi-Cal, so they need to stay in state. Next slide, please. So the blue area that the arrow points to on the coast, that's us. And it's a substantial part of California in terms of terrain and distance. And it was a challenge. I certainly had never thought of coming up here, and I know many other Californians have not either. But because of that, in a way, there's a lot of it that is unspoiled, and And also a lot of very hardworking, salt of the earth, immigrant type people that made it here and made their families here and have lived here for generations. It's a place that's attracted a lot of interesting, creative people in the past. Next. So size isn't the only challenge. But size makes its own challenge. For instance, it's difficult to have people come to the clinic one day for a labs and to come the next day for a medical oncology appointment, and then come the next week for a radiation oncology appointment, when each of those represents a whole tank of gas if they live an hour to 2 hours away from here, which is not unusual. The terrain, of course, is not flat. There are lots of gullies and valleys. The winter weather can be extreme. And road conditions, most of the little roads around that are outside of the towns, they're narrow and they're poorly maintained, and they're not conducive to a lot of travel. So the first winter that I was here, it was an El Nino year. And for several days, the highways in our area were blocked by mudslides, all of them. And the weather was bad, so air travel was not possible. Helicopters were sent out to try to get high-risk pregnancies out of the reservations to bring them down to the city. We nearly ran out of IV fluids and antibiotics, and that was one of my first lessons on how I had really changed from Stanford University to here. I was really on the frontier. Next. And by the way, that slide was to point out that our American Indian population is part of our daily life. We don't just say this is land formerly owned by. We have them all around us, and they're a vital part of our community. They have their own healthcare system in the United Indian Health System, and we also have an FQHC. So other resources. Now, this is where somebody accused me of recruiting, but you can recruit as a tourist. But if any of you want to come up and see what we've got, of course, we'd be very happy to host you. But there's a lot going on here. Multiple state and U.S. parks, 6 major rivers, good kayaking and swimming, Trinity Alps for hiking, Cal Poly Humboldt for university. That's been a huge asset. It was Humboldt State when I got here. It's now Cal Poly Humboldt. And the other great advantage is that Cal Poly Humboldt reinstituted their 4-year nursing program. And as you'll see from my talk, my relationship with nursing has been a major factor in my success. And there's a lot of other reasons to hang out here. Next. So what happened? I found out through the Medical Society's records at one point that there was no cancer care here before 1973. And in 1973, a group of doctors came up. One of them was a guy I knew from Stanford, where he had trained as an internal medicine resident. And he had a nurse who was able to start a peripheral IV good enough to give CMF. And he started phoning back to his university and got the recipe and gave it to a few patients. It was kind of amazing. But when I talked to patients later about that time, I said, what did you do if you had cancer diagnosis? And they said, you either die or move. And that was the idea that in my lifetime, in my child's lifetime, in fact, there was no cancer care in this area. And that's that whole blue area that I showed you on the map. But this group of doctors got a grant, $900,000 from the National Cancer Institute, to see what could be done to bring care to this area. And the result for the $900,000 was the American College of Surgeons accreditation and our relationship with the American Cancer Society. Radiation, which was given in a truck with a linear accelerator in it behind the hospital, and home-based hospice, which is still going on today. And shortly thereafter, we were able to recruit our first radiation and medical oncologists. I wasn't here at the time, but it's the royal we. We built vaults in the hospital basement for linear accelerators. The first linear accelerator was replaced in the year 2000 by one that was IMRT capable, but they were two different accelerators, which meant that if one of them went down, you couldn't easily switch patients from one machine to the other. And so there was often a delay in treatment. And it took a long time for repair people to get here. So we're about in the next few years to replace them again. But the philanthropy in the community is what has brought us these ones that we have now, which have been an amazing and improvement. Okay, next slide. Thank you. So I don't like to talk about myself all that much, but it has to, in order to, I have to get this story out to you. My happenstance was I was born into a family in Monterey that did not really value education so much, but I grew up to realize that that was my ticket for a useful life. So I started at high school level, getting a scholarship to a local girls preparatory college high school, which allowed me then to have the academic credentials to get into Stanford. And that was also just luck. And Stanford, I went there for all the other layers of education. I was an undergraduate, graduate, medical student, etc. But the medical school environment was incredibly interesting. I hope there are people on the call who can identify with this, but we called Stanford the Montessori Medical School. And it was all pass fail. It was an enriched environment. The admissions committee would put the right people into this environment, and out of that stew came things. So just to give you an idea of what I found when I got there, Henry Kaplan and Saul Rosenberg were still working. They began the idea of combined modality treatment. They got us ultimately to the place where we are now with the control of Hodgkin's disease, which used to be uniformly fatal. And a lot of our surgical training in the early years was staging laparotomy, which is not done anymore. But Arthur Kornberg was here, Stanley Cohen, Paul Berg, Ron Levy, Sarah Donaldson, Bob Carlson, and a lot of people who have just been giants in the field. And they were part of our daily life. And it was kind of amazing. When I look back on it, I realize what a great nursery school that was. Next. So my husband decided in his midlife crisis that he was going to move out to the country at the turn of the century. And when I initially came here, the decision was based on whether I wanted to stay married or not. And I dabbled in surgical practice. I maintained my Stanford privileges and also dabbled there, but I was not working full time on medical things. I was working for the California Breast Cancer Research Program and their council. I toured and worked with Susan Love, and I spent a year on Oprah's Medical Dream Team with Mehmet Oz, which I don't like to brag about too much. I helped design Stanford's first multidisciplinary cancer program. They had the idea that, gee, maybe we ought to bring radiation oncology and medical oncology and support services under one roof. And that had not been done before. So there was a committee that designed that building, and then we designed another one that's suburban down near the Apple headquarters. So when I got here, it was clear that the physical plant in Eureka was ready for something like that too, because our different cancer services are as far apart as we can physically put them on this campus. The radiation oncology is far to the west, and medical oncology is far to the east. And cancer support services is in a couple of trailers. And the challenge I have with that, and my nursing director partner also has with it, is convincing our employees that they're all part of the same enterprise. And she's been very successful in doing that, which has been great. So people know that even though they might be a quarter mile away from each other, that they're all part of the same team. Next. So when I got here, I stepped into a real problem I came to the attention of St. Joseph Hospital because in the early years, I I had done some projects down at Stanford, which got some attention from Navigant Consulting and a couple of other consulting firms. So just by accident, the CEO of the hospital had been fired. There were Navigant consultants all over the place and lots of physician meetings. And at one of those meetings, I was recognized as somebody who had been in Palo Alto. And the new CEO was encouraged to see what I had to offer. So that's how I first got involved. And when I started looking at what it would take to control cancer care, I found out that cancer referrals were totally tied up by the general surgeons. And they had no desire to have this changed at all. And they had cowed the medical oncologists and radiation oncologists into accepting that. So all care was sequential. It all started with surgery, and people got surgery, even if they would have benefited from neoadjuvant therapy, concurrent therapy, or something else. So there was a lot of improvement for a lot of opportunity for improvement in a medical system that was very resistant to any change. And that's what I stepped into. Next. So we started thinking about a multidisciplinary cancer center. What would it take? Because we had assets. We had some medical oncologists in private practice around the area. We had Dr. Harmon, who had taken over the radiation oncology department and is a master recruiter. And he recruited Dr. Join Liu, who came around the same time I became involved. And you'll hear more about him in a minute. But the hospital board thought, gee, maybe we can pull this together into a cancer program. But it was very clear after many evening meetings that we could not get a consensus on aspects of the finances or the operations, and that physician relationships were terrible. And they got more terrible. So at one point, the medical oncologists and radiation oncologists were at war with each other. And this is just one of those accidents that happened that propelled me forward. But they were accusing each other of malpractice, basically. And so the hospital spent $100,000 to bring in a team of textbook writers to adjudicate these cases, and then also to talk to us about what we needed to do. So they left with several recommendations, and they also gave a dinner at which they reamed everyone out for their unprofessional behavior. And at that point, they also said you need a formal medical director of the cancer program if you're going to go forward. And it was very clear that it couldn't be a medical oncologist or a radiation oncologist because they were still not feeling great about each other. So there I was, sitting there as someone had come to attention and became a surgical oncology leader of the program, which is not unusual out in the real world, but it was unusual here. And also I was a woman, there weren't other women. I still am a woman. And so it fell to me, and there was nothing except the radiation department in the basement and the other practices around. Next slide. So we had some assets. One is some of those people who were creating problems left the area, and we had new resolve in those of us remaining to rebuild and to provide quality cancer care. Dr. Join Liu arrived right out of his residency from University of Texas Southwest and became my partner in the sense that if I ever needed anyone to convince others that I had the gravitas to do the job, Dr. Liu was always there at my back. Both of us had been raised in NCCN guidelines, which were actually developed during my residency time. And we all thought the NCCN guidelines would never work because how could you possibly have best practice guidelines that would apply to everybody? But we learned to love them, just like many things. So we both had these university connections. But what we didn't have was we didn't have connections to the Commission on Cancer because our accreditation was done by NCI and NCCN, et cetera, but not by the Commission on Cancer. So I set out to do a bunch of surveys and interviews in the community to try to figure out what was needed and how to get it done. And one of the questions that I'd asked when I formed Bay Area Cancer Connections, I also asked here, which is, what do you know now that you wish you'd known before your cancer journey started? And another question that goes with that is, how could your care have gone better? So we interviewed, surveyed lots of community groups, lots of medical groups, to try to figure out what we could do. And then we presented a vision to the hospital for an integrated silo-free program of cooperation, which at that point they were all really happy to hear about because of all the prior controversy. Next slide. So we planned it with monthly dinners, where I got the guys, the other doctors, to be cooking with me. So I remember Dr. Harmon brought chanterelles one night, and Dr. Lewis chopping them up, and we would cook together, and then we'd sit down, and with giant Post-its all around the dining room, we would figure out what we needed to do next. The hospital gave me 2 really experienced, incredible nurses to begin the building. And my career, if it isn't clear, has been very dependent on nursing and my appreciation of nursing as a completely separate but complementary body of knowledge that we do best with, we cooperate with. And I would not have gotten through my surgery residency as the first woman matched in surgery had I not had the backing of the ICU nurses and the OR nurses at Stanford. But so Tim Talbert and Linda Rasmussen were the 2 here, and the 3 of us met together, and we decided we would start with cancer support services. And that, in retrospect, was a great way to go, rather than deal with clinical care right at first, because these are now built into the budget and the expectations. We got an oncology certified social worker, and we also formed an intern program with the local university. We have an oncology certified dietitian, financial counselors, and then a medical oncologist was recruited to the area who didn't want to join one of the private practices. He wanted to be in a hospital-based program. And so that was a new challenge. Next slide. So the administration donated the old convent, since the nuns were not living here as much anymore, and the administrative offices to be converted into our medical oncology clinic and infusion center. And ultimately, the private medical oncology practices in the area all eventually were joined us there. And we formed a dynamic tumor board, which was the way that primary care physicians who were aware that sometimes people needed neoadjuvant or concurrent chemotherapy, and that they have a way to refer to that. They didn't have a referral point for cancer patients. They only could refer to surgeons, and that they knew, some of them knew that that was not right. So our tumor board goes on to this day as a forum for doctors to discuss patients with each other, and for primary care people to participate, use their greater knowledge of that patient to advocate for them. And it's still a true problem-solving resource for us. And we call it our weekly nerd prom. But we like sharing knowledge there. Next. This was a little sideline, but it was a morale boost. We came to Stanford's attention in 2012. And actually it came about because we decided we needed a university partner. So a group of us had appointments with different cancer centers around Northern California. And then we invited them up here for site visits. Sometimes there was a repeat site visit. And then we asked for proposals. And the proposal that we got from Stanford was by far the richest. And it was a great morale boost for them to recognize that maybe we were on the right track for something special. I think they also wanted access to our clinical trials population, which included American Indians, which had been underrepresented, and poor people, which were definitely underrepresented in Silicon Valley. So it failed, but after 3 years, and it failed because of lack of support from the St. Joseph side, which is kind of sad, but at least we knew from the development of the program that we must be on the right track. And we owe a lot to Dr. Doug Blaney for recognizing that. Next. So this is what we are today. The lower left-hand picture is the old president's office for the hospital. It's now one of our infusion rooms, and it looks out on the convent garden. And in the upper right-hand side, we have some of us in the convent garden. We when we started to reform the program, there was one oncology certified RN, and now I think we're approaching 60% certified. Radiation, of course, still in the basement. Next slide. So medical oncology is far to the east of our campus. They're all in the same building, but it's a long stretched out building. So this is the former convent, and the reception area has now been redone into another reception area. We have our phlebotomist on site, who's now our clinical trials coordinator also. And we have a series of nurses who I needed to find some cancer nurses. So I went up to Med-Surg and just tapped on the shoulder people that I admired, thought were smart. And many of them, including these guys, have been there for this whole time. Next. So radiation oncology is on the west side in the basement. There's one of our LINACs, that's an Electa. And it's daunting. If a patient goes to one clinic only to find out that they're supposed to be in the other clinic, it's a long walk, and they need support sometimes to get there. Next. So we also still have cancer support services. We do lots of outreach events in the community. We're at the farmers market tomorrow, where we've done health fairs out at United Indian Health, and also some of the casinos. And we do regular food bank delivery, where we give food out, and then our dietitian is there with recipes and cancer fighting food. We have the Evergreen Lodge, which you can imagine we need, because sometimes people are getting, say, radiation. They can't take a 2-hour drive there and back every day, and they certainly can't afford it. So what happened with Evergreen Lodge is that the local Rotary paired up with the trades students at the local junior college, and they got the materials donated, and they built Evergreen Lodge. And later on, they built an addition to Evergreen Lodge. And it's a series of kitchenette containing motel units and other communal spaces for people to come and stay at minimal to no cost while they're getting cancer treatment. And it's also dog friendly, so that's been good. And our dietitian has a sense of humor. Okay, next slide. So this is our infusion clinic. Again, another view from another angle. You can see that people, are not totally crammed together, and that was hard to do. And we got a grant from our philanthropy department. Our outreach is Women for Wellness, and they gave us the money to get a mural painted in the really bland corridor leading up to the infusion center from the oncology clinic. Next. So up on the upper row on the left, that's what that hallway looked like before we painted it. And then we painted it. And then we also have a series of little notes there so that patients can leave notes for the nurses and for their care team. And that's been a real morale booster also. Next. The convent garden is right outside the, you don't usually think about wildlife and convent garden together, but it's right outside the infusion center. It's always been a nice place for people to go and look at nature while they're getting treated. But it also connects to one of the local gullies that crisscrosses Eureka. And as such, we have a population of wild animals that come by. And last 2 years ago, we had a woman who had a HER2 positive, large, terrible breast cancer diagnosed at her 6 weeks of pregnancy. And we managed to get her through her initial chemotherapy, through her surgery, through the delivery of her baby, and she came back in for her HER2 targeted therapy. And as she sat down for the very first time in months in her chair in order to get treated, this deer walks up, sits under a tree right in front of her, and delivers twins. So everyone thought this was an amazing event with probably some significance. But I just said, yeah, I think that doe is trying to show you up because she just had one baby. But next slide. They're cute. So we also have outpatient oncology rehabilitation. Linda Rasmussen got some of our early physical therapists into the STAR rehab program, and it was still going on, and they're still around, and it was great. Next. Community, the staff, none of this would have happened without an inspired and passionate staff who know that the patients they're taking care of are their community and their family. And they recognize the responsibility. It's not like that, somebody could go down the road and go to another cancer center, it would be okay. People feel an incredible sense of commitment to this program, and we have an incredibly wonderful staff. So on the far right there, we light up the hospital in October for Pinktober. We, again, are out at various festivals. This is the Apple Festival down in Fortuna. And we have outreach clinics, including head and neck screening programs and skin cancer screening programs, et cetera. And in the far left there is Dr. Joanne Liu, my buddy, and me, and one of the Sisters of Perpetual Indulgence, who does not live in the convent. Next. And with the local baseball team, which is a college-based team, has been going strong for almost 80 years, has always had winning seasons, and its mascot is a crab. So that got us on the cover of the National Cancer Survivors Day bulletin back when we decided for the first time to join National Cancer Survivors Day, because we had the crab. So Krusty the Crab is pictured up in the top with some of our nurses. A community member treated for prostate cancer came up with California Crushers, which is another local fundraising operation we have nothing to do with. They're completely independent, but we're their beneficiary. We have an inflatable colon when kids love to play with the polyps. This is the next picture to the right is Dr. Liu and the head and neck screening program. And again, some of our nurses at the ballpark. Next. So I knew we were doing something good, but I didn't realize that it was actually worth a lot of notoriety until about 2 years ago. And 2 years ago, we were surveyed, and we had a perfect score on the accreditation. And I had not ever heard of that before. I'd run into a lot of accreditations from trauma to OR to whatever. And it was sort of like finish the assessment and said, good work, carry on. And that was that. So that led us to think also, and probably I thought back to the Stanford time, is that, we're doing something right here. This is our meeting, a combined staff meeting of radiation and medical oncology, just to show you that we do get people together, and they do work now so much better as one team. Next. And then there was an article in July of 2023 in the ASCO Journal of Oncology Practice, where they went county by county through the United States with the hypothesis that rural cancer programs would always have a lower mortality rural cancer problems would always have a higher mortality than any urban or other program. So they went county by county using SEER data. And this is a map from that article. And the important thing to know here is that they did find some outliers. And the outliers in red are those who were urban but had a higher than expected cancer mortality. And the blue areas are the areas that are rural but have a lower than expected cancer mortality. So we were pleased to see that big blue blob on the coast. They speculated about things that might be responsible, like, is this a particularly affluent rural community? And that's definitely no. It's, is it near an urban center? No, it's far away, but somehow we managed to do it. Next. So we have a bunch of stuff going on permanently, which I don't need to probably read all of it to you, but we've instituted whole person care. The Poor Institute of Medicine has tried for 25 years by publishing a book every 5 years to get us to pay attention to whole person care. And again, this staff, which I can't say enough good about, has glommed onto that, taken it to heart. And we have now an oncology food bank, which was surprisingly needed. We have chair yoga taught by Linda Rasmussen, whose name you've heard before. We have support groups of our own. This is especially important since the American Cancer Society's local offices had to close, and their support groups went with it. And now we have substituting for some of that, and also partnering with other peer support groups in the area, like the Breast and GYN Cancer Project. We have money to help people pay for gas and to pay for hotels, especially if they have to go out of the area for consultations. We're looking for an looking for an angel fund for larger expenses that people have, like getting their cars repaired. And that will come soon. And then Evergreen Lodge, which I described to you before. And we take care of the staff too. So there's been a staff education fund that helps with people attending national meetings of their professional organizations and memberships there, and certification support and any other support that advances their career. And that's paid for largely by donations from doctors, but also donations from a few community members. We have a lot of fun together. Sometimes we get together with patients and in community organizations, but sometimes we just get together for fun. And we are looking at needing to buy a bunch of new equipment. And even with that, we haven't given up on a new building, but we're just continuing to improve with what we have. Next. So this is us. It's hard to describe what this place is, but I will tell you, it's very different from Palo Alto. And as my 12-year-old daughter told me when she first came up, she said, "Boy, Mom, you know a lot more about asphalt and septic tanks than you used to know. And boy, heating the home, everything is a little bit different, but the challenge is great. The scenery is gorgeous, and we follow on a great history of philanthropy, because the building on the upper right, which is the basis for a lot of haunted houses relevant to this time of year, is the Carson Mansion or the Ingomar Club. And it actually, they put it on all the tourist things, but you can't get into it if you're a tourist unless you go with a member of the club. But that was built by a lumber baron when lumber was big. And our history is a whole bunch of different extractive industries which have gone their way. But this is when lumber was big. There was a downturn in the sale of lumber, and Mr. Carson went ahead and got his employees to stay employed building this building. And it's full of all kinds of rare woods carved, all kinds of things that the artisans were just turned loose to do, and stained glass and whatever. And it was his way of keeping people employed during an economic downturn. He got them through that, and then on to the other future. So the word cloud is something that came from the staff at one of Priscilla's earlier meetings. And you can see that compassion is what they feel for their neighbors undergoing the challenges of this disease set. Next. So if you want to come for a visit, just let me know. If you want to come just to enjoy the area, see visitredwoods.com. It's an easy URL to remember. And I hope to meet any one of you soon. Thanks.
Thank you so much, Dr. Mahoney and team, for sharing your inspiring journey and remarkable progress in building high-quality, compassionate cancer care for rural communities in Northwest California. So with this, I'd like to open for any questions or comments. Lots of love in the chat, lots of claps. Thanks, everyone. Yes.
Yeah. Oh, I left, yeah, thank you, Sarah. I left out the transition from the Sisters of St. Joseph to Providence. And I still miss the sisters, although some of them come up for board meetings occasionally. But Providence it was a bit of a shock, but it allowed us access to a bunch of things we wouldn't have had otherwise, including next generation sequencing and molecular tumor boards and things like that. So we've had a merging of St. Joseph and Providence in the time that all of that occurred. And I did mean to put that in a slide and I left it out. So thanks for reminding me. But the Sisters of St. Joseph actually came to Eureka about 110 years ago. Amazing group of young women who took a trip at that time to a wilderness area that was basically a gold field. And we never succeeded that much as a gold panning area, but they came with the mission of looking around and decided the place needed a school. So they built a school. And then the pandemic of 1919 hit, and they decided, nope, this place needs a hospital. And so they built a hospital. And from that hospital, which is their flagship hospital, they built out their whole system, which I think was 37 hospitals when they stopped building out, of all emanating from Eureka. And Eureka was always known to be the hospital that would need the most support from the system, but that we were doing important things here for important people, like our patients. So.
And some lovely comments on the chat. Really beautiful work. Thank you for sharing your story. Such a labor of love. Thank you all for this impactful work.
Yeah, thanks. If you know of any other community that's got this in mind, please let us know, and I'll be glad to help now that I'm slowing down a little bit.
Ellen, I had kind of joked that perhaps you might be willing to do a spotlight on your work, but now I'm convinced CDOC needs to do a member spotlight on your team. I mean, wow, you're having like parties together and, and getting together with patients. If there's any picture you can share, I'm sure we can help to create the spotlight for you to put on a website.
I just stand back sometimes, and I'm filled with love for these people that work alongside me, and also for the patients who are already, some of them are already experiencing hardships, and they approach cancer with such courage and grace. And it's hard not to be inspired every day by that. It's an incredible place.
Thank you, Dr. Mahoney and team again. All right, Joyce, can we look at the next slide? So before we provide the next two slides for new CDOC opportunities, I'd just like to open the floor for any Cancer Center representatives in the call who would like to share some resources or updates. And also, if you prefer to list your events or resources, you can just email us at CDOC and we'll gladly promote it on our listserv after we review it.
Sheila, I'd like to take an opportunity because I am going to have to jump off of this call in about 5 minutes or so. If I can share, if you can provide the slide that we prepared. And I also want to say thank you so much, Dr. Mahoney. It was very just inspirational and amazing to hear all of that background and just wonderful work. Thank you for your time and all your dedication, and especially coming today as well. Thank you. Okay, so what I wanted to present, Sheila mentioned this briefly, but the CDOC Survivorship Work Group is embarking on a new initiative that aims to work with CHWs and those who are trying to get certification or are already working in the field, but we really want to focus on establishing a cancer care track. So what we learned is the Department of Healthcare Access and Information is the department here in California, or the agency, I should say, in California that that's currently working on standards for CHWs. They're working with several community members, CHWs, gathering feedback, and they're proposed to have some type of recommendations out in June of 2026. And so our work group has been working on really trying to get some type of cancer care track for CHWs established in this certification. So what we'd like to do is build capacities to support cancer prevention, navigation, and survivorship statewide. And it would be coalition led, and we're hoping it will be cancer center driven, because we have already met with City of Hope and they have a complete training program on prevention and screening and research. We also know that there are models from ACS, the Lion model, and GW Cancer Center as well. So we want to take a look at all of these and figure out how we can create some type of just curriculum and offerings for a cancer care track. And then we have Daniel Rivas with our survivorship work group, who's also working on a survivorship module that we would integrate into there. But we would look to work with a group of folks to help build this out and develop it. And apologies if the I have that in the back of me, so sorry if that's getting in the way. We are going to be looking at HPI's framework, and they have these 4 pillars. So we'll be working off of those pillars. And the timeline, as I said, we hope to get some type of information and whatever it may look like to HPI by mid 2026 as they're working on these standards. So with all of that said, we've just been discussing this. We've met with City of Hope. We've met with our survivorship work group several times. We've been doing a lot of background work to figure out who is trying to create these standards, what colleges are offering these certificates, et cetera. But we would like to convene a work group to help us move this forward. So if anyone is interested in doing this work, please let us know. And at this time, I wanted to see if anyone from City of Hope had anything to say, or if anyone has any comments, anything to help us move this forward. But again, this is something that we'd like to open up to for those to join.
Thanks, Shante. This is Kimlin, professor at City of Hope. So we are thinking and hoping that CDOC could be the champion of this initiative, which would leverage the work of and the capacity and the reach of CHW to really build a capacity in the oncology arena, because we know that CHW do amazing work in primary prevention, but overall there's this huge gap in terms of specialty care, including cancer care. And so this would be based on the bandwidth and working out with public health department and all of that. The vision is the whole continuum of cancer care, right? From prevention to screening, diagnosis, helping with pathways to care, including precision medicine and clinical studies, and of course, survivorship. So we welcome collaboratives from anyone and within CDOC to help advance this. And we think this is the right time. We know that cancer is a huge burden in the state, and hopefully this would be a statewide initiative. Right now, we have this project that's very localized in City of Hope, and we're reaching some community health workers now through Vision y Compromiso, as well as other organizations, but this could be expanded throughout the state to reach community health workers everywhere. So.
I'm not sure if you can see, I just raised my hand, but I just want to say, Kimlin, thank you, and to Shante for highlighting this opportunity. This both seems, timely, but also like oh my goodness, why haven't we done this before? So that's the perfect idea, I think, for us. And I think it will really meet a community need. I think we see a lot of CHWs who get asked to come in and support, not just in sort of screening access and stuff, but what happens when someone's diagnosed and have to make these difficult decisions around treatment and access and all those kinds of things. And they feel like very ill-equipped. I know some of these trainings that you've mentioned, like the Lions, is something that's actually been a little out of reach for our CHWs because they either had to be a navigator in a clinical setting or et cetera. And so if this is something, the module that will be available without having to have for example, pre-existing certification or anything like that, or this is a certification, part of the certification process, I think it's really great, and I'm happy to support.
Thank you, Sarah.
Thanks, Sarah.
I see a comment from Marco. This is super interesting. The need is there. Would love to talk more about implementation, as we've seen some interesting distinction between internal navigators at Cancer Center, navigators offsite attached to primary care, or navigators unattached to one. Thank you, Marco.
Spot on comment, because we do want to reach the community navigators. Yeah.
And we will also be including this ask in my follow-up email with all the Cancer Center representatives. So everyone can see our new opportunity as well. I don't see any other comments.
I just wanted to actually ask Kimlin, I mean, I think what you're doing is and Shante, you're asking for people to kind of be part of the group to design the initiative, but there might be hopefully later opportunities for people to come on board, for example, if they want to pilot test, because I could see that certain, depending on bandwidth or the groups that we're all involved with, the pilot testing could be really of benefit as well.
That's
Yeah.
correct, Sarah. Yes.
Yes, so all of the above, because we have to build and share, get feedback, and an iterative process to make it fit the communities that we're working with.
I don't know how many of us are CCSG, so NCI funded, but I know that we foresee budget restrictions taking place maybe sometime next year with the new notice of funding opportunity, so maybe by next fall. So I also feel like it's really good to strike now, well, when we haven't been dialed back, because I'm not confident that that federal alignment will allow us to do some things in like this time next year. I don't want to be a doomsdayer, but I think we all know that things are getting cut left and right. So I want to strike now while we still have the bandwidth, the expertise, and the opportunities.
Thank you, Sarah. And that leads us to this next slide, which Sarah and Allison, oh no, the previous slide, Joyce. We'd like to see where opportunity for partnership amongst our Cancer Center partners are. And yes, great observation. That's correct. Thank you, Alice.
I'm wondering whether we might need some, I know we don't have too much time, but one thing I'd like to throw out, because this is, I think, a subset of this entire, the Cancer Center working group we have. For the NCI funded comprehensive cancer centers, I do feel like we need to do some strategizing. So for example, if community engagement will be cut or no longer a funded mandate, right? So which basically means that we will get unfunded. What could be the implications for the communities that we serve, the numbers who we reach, the people who we screen, and diagnose. I just feel like I'm not sure if any of us have any kind of a modeling expertise, but I think it would be an important exercise to go through so that we can communicate what the potential could be if and when our state or our federal government is talking about cuts to our, to our community outreach and engagement mandate. So I'll just throw that out there if anyone's interested.
Elise, go ahead. I see your hand up.
I was just like, yes, yes. I agree with what you're just saying. In particular, I'm sort of looking at this list, and I wonder if thinking about, particularly around screening, we have this issue. But thank you, UC Davis, for doing so much work to inform us all of the late stage diagnoses that are on the rise in many of these communities. And absolutely, we're doing some modeling, and we definitely have some of those skills, and I'm sure others do as well. We should be thinking about not only what could we do together now to help to try to address some of the early detection, particularly in those shared areas where we see a lot of late diagnosis, particularly where we have evidence that we can make a dent in that late diagnosis and by working together. But then also projecting out exactly what you were talking, Sora, about saying, if we know we can impact these many communities are impacted, what is a likely impact of various, and we don't have to be completely focused on the cancer centers even, but sort of generally, what are we seeing in terms of increases in insurance? But like, there's like so many moving parts right now. And I do think that modeling, per Sarah's point, is a really great way of us being able to articulate, like, what do we expect to happen? Like, what's going to happen to the need? And what's going to happen to supply in the next few years under different scenarios, without even picking a scenario to say, like, this is the one you should do. We can provide people with a lot of information about what the consequences are of action or inaction. Thank you, Sora.
Thank you, Elise.
And perhaps it's a mistake to actually focus only on the NCI funded ones. I mean, I think, Dr. Mahoney, you talked about we all are accredited by the Commission on Cancer. We're all affected by the changes to Medicaid. We're all affected. So maybe actually we should think bigger and broader and more inclusive, because I think we're talking about impacts in California to all of our populations. But I don't want to assume that the comprehensive cancer centers that are, don't have NCI funding or have different NCI funding want to be immediately involved. But I want to throw that out there. Okay. Especially, I mean, when we talk about screening and access and all these kinds of things, I think we're all dealing with it. Okay. I'm wondering, Shantae, Sheila, that maybe we can carve out some time at the next collaborative, and between then and now and then, we just make sure that we've got a list of people who are interested in working on something.
Absolutely.
Because we don't know, not everyone's here, so that we can plan out an agenda.
We'll do that, Sora. We'll definitely add that to our agenda. And the next slide actually shows the different dates for our quarterly collaborative meeting in 2026. Can you believe that? Again, thank you, everyone. And as a quick reminder, we'll maintain the quarterly format of these collaborative meetings, and all the 2026 dates are shown on your screen. The Cancer Center hosts are identified alphabetically, and but if you'd like to present a project, so just please feel free to email us at cdoc, and then we'll put you on our rotation host for the next Cancer Center presentation. And then also, please help us complete a short webinar evaluation. We read all of your comments. It has been dropped on the chat, and we'll be sharing any follow-up recording and all of these new opportunities to all the Cancer Center representatives after the meeting. I don't see any other comments. So again, we look forward to your continuous collaboration and with our next collaborative happening in January 2026. Thank you so much for sharing your valuable time with us. Oh, Sarah, go ahead.
I just tried to click on the evaluation. Is anyone else having problems like being verified as a human?
Oh, yes.
Or are
That's
you
like a contact warning.
It's not letting me go. I don't think I'm getting verified.
I'm human, Sarah. I'm human.
You're
click
human
it.
and you got in. Okay. Okay, I'll just let it continue to verify me. Thank you.
Thank you, Dr. Mahoney. Yes, we will definitely share your presentation slide deck. We've got interest on your slide presentation, so that will be included in our follow-up email.
Yeah, thanks so much, Dr. Mahoney. It's wonderful to hear about your work.
My pleasure. I was kind of starstruck, but it was really nice meeting all of you.
Thank you so
I'll
much.
find someone to take the tumor board ever so often so I can attend.
Thank
Understood.
you.